pleasure to be here. I feel like a fish out of water because I'm a child neurologist and you're not. But back when I started in child neurology, they were much closer together. And I actually began my research work in lysosomal storage diseases and dealt with actually basic science of those disorders until 1983 when I saw the first girl, or one of the first girls in this country with Rett syndrome. I have disclosures which are not that important. And these are the learning objectives which you can read. Gary Vockley mentioned yesterday that their study was in the Rare Disease Clinical Research Network, which took me back to 2003 when we applied for a grant for that, and it was funded, and actually that funding ended in 2021. So we survived 3 rounds of grantsmanship of that disorder. We enrolled over 1,800 individuals with Rett or Rett-related disorders and more than 1,600 with Rett syndrome. But in 1983, that is when the first English language publication that made it around the world, published by Bengt Hagberg in the Annals of Neurology. And with that, Rett syndrome became international. It was at the same time that the FDA had a Rare Disease Act approved by Congress. In that, they defined rare disorders as, in this country, as affecting fewer than 200,000 individuals. But they also made it easier for drug companies to market or develop and market products for rare diseases. Up to that time, 38 products had been approved for rare disorders. In 2002, when the Rare Disease Act of the NIH was funded by Congress, about 200 additional products had been identified and approved by the FDA. And since that time, many more have been approved. So I think the Rare Disease Network has really done a remarkable job in detailing research in these rare disorders. Unfortunately, funding is such that it doesn't cover a whole lot of disorders. But with that in mind, let's talk about Rett syndrome. So Rett syndrome is a rare disorder. It affects about 1 in 10,000 female births. It occurs mainly in girls. The majority have mutations or variations in the gene MECP2. These are generally de novo. They arise from the paternal line, but these are from rapidly dividing germinal cells. So the father is not affected, so they are de novo. Occasionally, there are mothers who have the disorder, have the variation, transmit that to a daughter. In many cases, the mother is completely normal because of complete skewing of X inactivation. In other cases, where there is moderate skewing, the women have mild or moderate developmental disability, but no other issues related to Rett syndrome. About 4% of individuals lack variations in this gene. Up until about 2000, it was written in the literature that males didn't survive with this disorder. It's lethal. However, if you go back to the pre-mutation era, males were described, and since that time we've had a number of other males described. You can still find articles which say males' Rett syndrome does not occur because it is lethal. However, we have now identified close to 100 males who have variations in the gene. Many of them have a very severe neonatal encephalopathy and would not survive a long time without ventilator assistance. Some of the boys, however, have classic Rett syndrome, and that is because they have either somatic mosaicism, so they have 2 populations of X chromosomes, or, and I've seen one of these boys virtually, he has Klinefelter syndrome. She has 2 X chromosomes. Other boys meet some, 1 or 2 characteristics that are diagnosed with Rett syndrome, and we call those male Rett encephalopathy. And there are other boys who have just simply a developmental delay. Now the question is, does she have Rett syndrome? And the clinical criteria are as follows. It's a typical disease progression. They look normal at birth and for the first 6 months of life. However, if you delve deeply into their history, you find out that maybe she was too good. She ate, she slept, she didn't cause a fuss. And if someone had bothered to measure head circumference, you might have noted a deceleration in the rate of head growth of around 1.5 or 2 months of life. I don't know why it's so hard to measure head circumferences, but this day and age we see a lot of that. Then there's a regression of skills, which is followed by stabilization. And the core criteria are partial or complete loss of speech and hand use, either absent gait or abnormal gait, and then the classic stereotypic hand movements, which are either hand wringing, hand patting, hand finger rubbing, hands in the mouth, hands behind the back. Each girl seems to have her own repertoire, and they may occupy the whole day or may not. Atypical Rett syndrome, on the other hand, is individuals who meet 2 of the 4 criteria in any 2 of those 4. Atypical Rett syndrome represents about 15% of the total Rett syndrome population. They also, in addition to meeting those 2 of the 4, have to meet 5 of 11 supportive criteria. And these are a variety of things that girls with Rett syndrome do. The stages of Rett syndrome have gone through some variation over the past 30 or 40 years. We kind of just ignored these because they didn't make a whole lot of sense. That is, you could go from stage 2 to 3 or stage 2 to 4, because stage 4 requires that individuals don't walk. So we kind of abandoned those criteria. Stage 1 is really the period during which they have the delayed or abnormal development, which may be subtle and missed. And then that is for the first 12 or 18 months of life. Stage 2 is during the period of regression, where they lose these skills that I mentioned and develop the typical hand stereotypies. That may run from 12 months to 30 or 36 months of life. Then there's a stage 3, which is sort of a recovery period. During the stage 2, they are may be very difficult to interact with, push their parents away, cry uncontrollably for long hours at a time. And it's during that time that these girls often receive the diagnosis of autism. But following that, they seem to come out of that, and they develop this kind of stationary or pseudo-stationary phase when other features of Rett syndrome emerge. And we'll talk about a little bit of that later. And then after 10 or 15 years, there's a late motor deterioration phase. So early on, these girls are very hypotonic, almost floppy in some regards. Gradually, their tone improves, and so it becomes normal, and everybody thinks, well, that's great. But during this late motor deterioration phase, there is an increase in tone, or actually a rigidity. So they may develop features similar to those of Parkinsonism. They don't have necessarily the pill rolling, but they pause in their gait. If they walk, they pause in their activities. During the last 7 years of the natural history study, we recorded the top concerns of parents. We gave them 24 options they could select, and a free text version they could write in whatever they wanted. These are the top 5 The number one concern of parents is the inability to communicate with their daughters. They can't figure out what she wants, and they don't have any ability to get a response from them when they ask her question. Seizures are the next most common, and then roughly the same are inability to walk, lack of hand use, and constipation. Where's constipation come from? Well, about 90 or 95% of these girls have constipation, which is really, really difficult for the parents in many cases to manage. So Rett syndrome is a lifespan disease. There are different features, they occur at different times. Early in childhood, we have to give attention to growth, nutrition, and GI issues. These children tend to be small. They rarely achieve 5 feet in height, and they rarely exceed 100 pounds. There are exceptions, of course, but this is generally the case. Nutrition is a problem, and GI issues really from top to bottom. During later childhood, after the regression has ended, there are many issues that appear, which could be seizures, breathing difficulties, either hyperventilation or breath holding, occurring generally while they're awake, scoliosis, or further GI issues. During adolescence, one becomes concerned about puberty, and puberty is actually one of the things that these girls appear to do normally. They go through puberty. However, about 25% may have precocious puberty, and on average, they enter menstruation about 6 months later than the general population. Scoliosis becomes a big problem at around the time of puberty. Seizures continue to be an issue, and nutrition continues to be an issue. During adulthood, there's a big problem. School ends. What do you do with your daughter when she's not in school? It means that generally one of the parents has to give up working unless they have a very good daycare program in the city or town where they live. Bone health issues are important also. Interestingly enough, girls with Rett syndrome have a high incidence of non-traumatic fracture or minimal trauma at worst. About 30% of girls will have this. And there are motor issues that come along with adulthood. And lifelong, we have to think about therapy programs, whether it's physical, occupational, or speech-language programs. Survival in Rett syndrome, however, is quite long. Average survival is over age 50. So that means if the girls are 50 or older, the parents are 70 or older. And in that case, it may need to consider where the child or the adult is going to be cared for in the future, whether it's a group home or other care provider, such as a sibling, another relative, so on. It's also important to review the IEP regularly, and when they begin to approach majority, to be certain that the parents have guardianship and conservatorship. As it would be terrible to show up in the hospital at age 20 with appendicitis and you can't give permission for your daughter to have her surgery. And the conservatorship is to prevent the federal government from taking any money that may be left to her. So it should be left in a trust. So why is the diagnosis delayed? Well, first of all, early signs may be missed. Maybe someone didn't measure that circumference or didn't really ask all the right questions. On the other hand, the delays in diagnosis may be minimal, and head growth may not have declined. The delay may be subtle, but if you need to pay attention to the family, if they say, you know, my daughter didn't walk at the same time as her siblings, or she doesn't walk yet. Loss of skills may be partial. They may not achieve words, but they may have babble and lose babble. That growth may remain in the normal range for up to 20% of the individuals. So microcephaly is not 100%. That used to be one of the criteria. And male sex. It's a boy, can't have Rett syndrome or related disorder, and that's wrong. But the bottom line is delayed diagnosis means delayed intervention and delayed medical monitoring. So the key points here are characteristic pattern of disease, regression followed by stabilization with very slow progression generally going forward. The early features of regression may be very subtle and developmental delay may not be appreciated. It's mainly in girls, but boys need to be considered. The majority have a variation in MECP2, but not all. And 3 of the 5 top concerns are related to the core criteria. And finally, not everyone with an MECP2 variation has Rett syndrome. I was very interested in the report this morning from North Carolina. They identified 2 girls who had MECP2 mutations. Now, one turns out to have a classic and serious mutation. The other one has a C-terminal deletion, which may or may not produce symptoms at all. And time will tell. So just because you have a mutation in MECP2 does not mean you will get it, either because of moderate or severely skewed exon activation. So symptomatic treatments. We've made a lot of progress over the past 20 years in this. I think what we really relied on is the development of core guidelines for the management. We think that the primary care physician, pediatrician, internist, if we get there, should be the quarterback. You take care of annual visits, do the usual blood tests, check the other items that are listed here. The typical blood tests are what we do for all disorders, but a vitamin D level is really important. We stress that every visit, or at least annually. And the ECG should also be assessed. There may be prolongation of a QTC interval in 20% of individuals. If that's positive, they need to be referred to a cardiologist. Generally, it can be managed medically. We had one girl with a QTC value of greater than 600 milliseconds. We had to have a pacemaker to maintain their normal heart rate. It's also a disorder you have to recognize it takes additional time. I heard yesterday one group talking about spending an hour or more, and we routinely spend an hour or more when we see these girls. And when they're new patients, because of all the issues that are involved, we have, believe it or not, spent as much as 3.5 or 4 hours. We ask the caregiver or the parents to maintain a binder of all information. And you will be shocked by the number of times we call up the parents because we need the DNA test to get treated for the disorder. They don't have it. You need to keep it in a binder. Keep it all the time. Keep it on up to date. And specialty referrals are essential only at the time you need that expertise. The other thing is to incorporate what the caregiver says to you. Remember, the caregiver is with the patient or the girl 24 hours a day. We're there at most an hour or 2 once a year. So you have to take what they say and take it seriously to heart. You have to pay attention to their concerns and not ignore them. They may raise concerns about GI issues, scoliosis, and behavior. You'd be surprised at the difficulties that these girls can cause for the families for their bad behavior. So the current treatments are basically for the medical comorbidities. Over the years, we have developed favorites, and they vary from physician to physician. But we deal with all of the issues listed here. And while these treatments are generally beneficial, they may be variable in their effect or be completely ineffective. So for epilepsy, first of all, you have to be certain it's a seizure. We don't necessarily trust anybody that they say that my daughter's having a seizure. The breath-holding events can be so substantial that they actually pause and look like they're having a seizure. So in that situation, we often require video EEG to be certain that what we're going to be treating is indeed a seizure. There's a large number of medications. I have my own favorites, just because I'm an old guy and I like the older medications. But there are other medications that may be considered, like clonazepam or clobazam. But also, we've seen situations where some of the really old preparations, like phenobarbital or phenytoin, have proved effective when others have failed. Cannabidiol is popular with families now. In some cases it works, and in some cases it just puts them to sleep. There are a variety of rescue medications that we recommend, and I don't have any particular choice over them. And in 5% or so of the individuals, medications are not effective completely, and we use either a ketogenic diet or a vagal nerve stimulator. In general, seizures are relatively infrequent. By relative, that's one seizure every couple of weeks. You rarely see a child that has daily seizure events, but when that occurs, then we have to pull out all the stops. GI issues are really a problem from top to bottom. Girls don't chew and swallow right, and if they don't swallow right, sometimes it goes down the wrong tube. So in those situations, a swallow study is essential, and it may require thickening of the foods, either with honey or thickeners. GE reflux is also common, and I personally, we are proponents of proton pump inhibitors, but H2 blockers may also be used. Delayed stomach emptying is an issue in some girls, and there are medications for it. I do not like the metoclopramide. If I were in charge, I would eliminate it from the pharmacopoeia. It produces side effects which are terrible. Constipation is the leading problem. More than 90% of girls will have constipation at one time or another, or all the time. We use a Miralax or polyethylene glycol, magnesium, milk of magnesia, sometimes together, or a sedative. The other problem, just to touch on, is drooling. Some of these girls drool and keep a towel or bib wet most of the time. Now, you can't treat that completely, but we do when girls need to go out and be more or less presentable. We use atropine eye drops, but we have it put in a tube that or a bottle you can squirt under the tongue, drop on either side, and you can do that once or twice a day, and it turns out to be pretty effective. And musculoskeletal issues are significant. Tone that gradually increases, or rigidity. Baclofen has been used for this. It can be given orally, which may produce sedation, or it can be given by an intrathecal pump. Some parents reject that kind of surgery, but it's definitely worth considering. And botulinum toxin can be used in a limited number of muscles at a time, but it has to be done by someone who knows what they're doing and they put it in the right place. Surgical correction of a variety of orthopedic issues is essential. Scoliosis in our hands requires operation in about 20% of individuals. Some have torticollis, contractures, or hip subluxations, which require surgical intervention. Sleep is a problem. They say if mother isn't happy, then no one's happy. And if you don't sleep for 2 or 3 nights because your daughter is awake and screaming all night, you're not in very good shape. So we use gabapentin, up to 30 milligrams per kilogram at bedtime up to age 6, and after that we use trazodone in various doses as required after 6 years of age. People have used antihistamines. They may be effective for a few nights or a week, but gradually through tachyphylaxis they lose their efficacy, and you have to stop. You can start them again after a period of time, but it's not a long-term management. And for those individuals who are able to get out of bed and wander around and the parents are asleep, a sleep-safe bed is really something to consider. I mentioned the issues of bone health. Decreased bone density is very, very common. I mentioned the fractures. Check the vitamin D level at least annually. And we like to keep the vitamin D level above the midpoint of the normal range, not at the minimum value. If necessary, bone density can be attained. Just know that a densitometry study generally is going to require sedation. There are a variety of medications, including the parathyroid hormone, Prolia, or bisphosphonates. One of my colleagues doesn't like bisphosphonates because while they make the bones stronger, they make them more fragile. The behavior I mentioned is an issue. Anxiety is present at most every age. Also, self-injurious behavior is present. I didn't touch on that, but we do have medications for that. They may react poorly to loud noises or crowds, so it's difficult to take them out to the restaurant or in the mall or shopping. Or even if they walk, including within the house, they may have difficulty with uneven or different surfaces. So walking from tile to a rug or vice versa. Or I had a girl who wouldn't walk down the sidewalk if it had a grate in it. She stopped. For anxiety, we found that escitalopram or sertraline are very good agents for that. These are long-acting drugs, once a day. They take 3 or 4 weeks to work. Parents may become anxious and may increase the dose. And there is a possibility you can use too much and actually make them more difficult. Another recommendation I mentioned here, and I mentioned previously, annual ECG, blood tests, and important to review the IEP and so on. The key practical takeaways here are multi-system disorder. It's crucial to incorporate individual issues and the caregiver's perspectives. Management requires a multidisciplinary team. There are many guidelines available online at rettsyndrome.org. You can get them easily. We use a variety of medications and annual blood tests. So the new therapies, I'll touch on just briefly here. In 2007, Jackie Guy and colleagues in Edinburgh with Adrian Bird showed that in a Rett knockout mouse, if they had the FP2 gene under the control of a tamoxifen stimulator, they could reverse the course of the disease when they provided tamoxifen. Even after this symptoms onset. So mice could be several months of age, significantly affected and improved dramatically. Not 100%, but improved dramatically. And that led to hope for more meaningful therapy. Around the same time, Daniela Tropia and a group at MIT noted that if they use a terminal tripeptide of the IGF-1 factor, which interacts with the IGF-1 receptor, they could show in an animal model an improvement in the features both at the physical level and also at the biochemical or structural level. Neurin Pharmaceuticals modified this by putting the methyl group in here, which extended the half-life of the compound and also allowed it to become an oral agent. And they funded 2 trials, adults and children. Phase 2, which showed efficacy and demonstrated safety. And after Acadia took this over, because it was a much bigger activity, and out of 187 individuals divided equally, roughly, in placebo and drug groups, these were the results from the caregiver scale, which is the Rett syndrome behavioral quotient, and the clinician scale, which is a improvement scale. And you can see over a 12-week course that both of these improved. Lower scores, that indicate improvement. Subsequently, the Lilac trials were extended for a period of a couple of years and showed that RSBQ again and CGI continue to improve. I should say that diarrhea and vomiting were significant issues at the first trial and continue to be in the follow-on trials. The Daffodil trial in younger individuals led to improvement as well in all 12 individuals. So trofinetide then was approved in March of 2023 as the first agent for direct therapy of Rett syndrome. I won't go through all of this in detail, simply to say that if diarrhea occurs or vomiting occurs, you can either cut back the dose or pause it for a period of time, or if necessary, even stop it. Individuals with severe or moderate kidney disease should be excluded. There are a number of emerging therapies that have been trialed: blarcamesine, the company Anavex, ketamine, which has been completed. It's now being written up. I can't release the results, but blarcamesine actually failed because the RSBQ didn't differentiate placebo from the drug group. Cannabinoid trial, different from the cannabidiol trial, is this drug is being run in Australia. And again, I don't know the results of this. And there are many, many agents that are also being tested, mainly preclinical one. So 2 gene therapies, one by Taysha. This is originally for adults in Canada, recently approved for children in the US. It's a single administration. It's by intrathecal administration. It uses an AAV9 vector with a mini MECP2 gene and controller to prevent overexpression. Why don't we want overexpression? Well, if you have too much expression of MECP2, you get MEC duplication disorder, which is equally as bad, if not worse, than Rett syndrome. So we have to be very careful about dose delivery. 4 individuals have been treated, 3 adults and 1 child. The total group is supposed to be 12. They're been approved to move to adults in a higher dose, and 1 of these adults had received that. The second trial is Neurogene, approved in this country for females 4 to 12. Is an AAV vector with a full-length mini gene and controllers. Again, single administration. This is an intraventricular injection. It was initiated a year ago in June. 3 individuals have been treated to date. Unfortunately, the company hasn't allowed the results to be released, although the investigator told me he knows the results, and I think they're positive. Neurogene was approved by the FDA for a START program, which gives them special access to the FDA. I don't know if you can see this slide. I can't see it here, but it lists the number of drugs that are have been in phase 2, phase 3 that is, phase 2 drugs, drugs on the left that are in preclinical stages. There are, in addition to the gene therapy trials, there are DNA or RNA editing, X chromosome reactivation, so you reactivate the normal X chromosome in the cells and hopefully don't reactivate or turn off the normal X chromosome in the other cells. And so here are the key practical takeaways. This is progressive neurodevelopmental disorder. You need to address the patient caregivers' concerns as well as the patients. Multidisciplinary team is essential. Symptomatic treatments are available and are generally doing very well. Trofinetide is a frontline therapy which is effective in improving communication, interaction, in some cases improving gait and hand use. It is not effective, not useful for everybody, because if you have diarrhea bad, you can't take this medication. There are other agents that have been under trial, and additional agents are being considered. So with that, I thank you, and thank all of my colleagues that participated in this study. We now, Julie mentioned 18 centers of excellence. Actually, I think there are 4 or 5 more have been approved last month. So we're over 20. And at least one of those centers is in Florida. We didn't have a center in Florida for all of the 17 years of the natural history study, which is not good. So thank you.